Welcome to CRH Talk, where we feature rural health professionals and dive deep into prevention, treatment, and building lasting health.
Welcome everybody to CRH Talk, where we focus on rural health and what we have going on at Cody Regional Health. So I have Dr. Travis Graham, and he is our radiologist here at Cody Regional Health, and I would like for him to talk about something really cool that people may not know on the back end what we're offering, but it's important for you to understand too that we have your best interest at hand when it comes to your health, and our technology is a part of our mission here, and that's having those advanced technologies. And so Dr. Graham is graciously taking his time to explain a new technology and a new table that we have for breast biopsies. And but first, for those who don't know you, I've never had a mammogram.
Okay.
We'll talk about that later, but I'm not at that age yet, so some people don't know what you do and how you do it and how long you've been doing it. So maybe tell us just a little bit about you and what you've been doing.
I grew up in Basin, Wyoming, so not too far away, about an hour away. When I was studying to get into medical school, I actually lived up at Wapiti for a while, and that's where I studied for my entrance exams to get into medical school, and I was a volunteer here at the hospital before then. After I got into medical school, I did that, went to my radiology residency training, and then came back. My wife's from Cody as well, so we're invested in the community and want to be here.
Awesome.
Radiology is the field where we use imaging to diagnose disease and also sometimes to treat things. A lot of people don't know that we do a lot of interventional things in radiology. For instance, if you might have fluid in your abdomen or fluid in your lung, we might use the ultrasound machine to take that fluid off. Perhaps if there's maybe a tumor in your liver or your lung, sometimes we'll address that on CAT scan and do a biopsy that way. It's less invasive than perhaps going to the operating room. So the stereotactic breast biopsy, or the breast biopsy table that we're talking about today, everything in radiology is tied to technology. We're one of the fields that is so tied to technology moving forward. A mammogram, typically people recommend you start that at age 40.
I thought so.
And if you have perhaps a strong family history, people will suggest doing it 10 years before that time. There's also other ways we can evaluate people via MRI, ultrasound for the breast, but mammography is kind of our beginning point. In the old days, we used to we would do two views of the breast, and it's just a kind of a single 2D image. We do like an image like this, we do an image like that, and the 2D images are great, and that's what people used for a long time. When you're younger, or have particularly dense breasts, sometimes it obscures things. It's like looking at a picture, but there's so many things overlapping one another that sometimes it can be hard to see breast cancers that are subtle. So we have what's called tomosynthesis, or 3D mammography here.
We just got
the
that.
foundation and the hospital is really nice in helping us move forward with that technology. So we've had that for a little while now.
2 years?
No, longer than that. I have to see, maybe 3 or 4.
Oh, really?
Yeah, we've had it for a while now.
COVID's put my brain.
I know. Maybe even 4 or 5. I have to look. We've had it for a little while now, but it's really nice. So instead of taking just the 2D images, like one image, we can take a whole sweep of images across the breast. So multiple images across an area, and so you can pinpoint those areas that might be of concern. So we pick up a lot more things than we used to in the past. The question is, if you see an abnormality, how do you biopsy that or sample it or see what it is? And that's where stereotactic breast biopsy comes into play. So that's a technique where we use the 3D technology, and a woman might lay on a table. You could always Google this if you wanted to, but it's stereotactic breast biopsy. A woman would lay on a table, and the machine will look at the area of concern that we have. We'll mark it on the computer screen, and it will take a picture like this and takes a picture like that, almost like a game of Battleship, where you see like the two things, the lines intersect, and we know where to target or where to go. And so it's particularly helpful in women who have maybe calcifications in their breast, or really small mass, or an area that looks a little distorted. We've done stereotactic breast biopsy also here for a while now.
9 years.
Is that what it is? Yeah, it's been
I know that because
we brought
when
it
I
here.
first started here, we just got the machine.
That's right.
So,
Karen Beamer, who used to be our radiology director, she's the one that brought it here, and she and I and Dr. Cross did those, so that was great. Patients wouldn't have to go to Billings or far away to have that done. And that was a great technology when we had it. And like anything, things become more progressive and advanced. So a typical stereotactic breast biopsy, a woman would lay on her stomach, her breast would go through like a little small area in the table. Right. The computer would read it and tell us where to go. After we take a few samples, we'll take those samples and put them in a container, and we have to take them across the hall to x-ray it to see if we've got the area of concern.
Leaving the woman on the table.
On the table,
right.
Compressed. It's not very comfortable.
Not very comfortable.
No,
yeah.
no. It's still fast, and most people say, oh, that went so much quicker and it was smoother than I thought it was going to be. You know, back in the old days, you'd have to go to the operating room or something else. So we partially brought this here for Dr. Welch and Dr. Eder, our surgeons, just to give a more targeted approach. So that took longer. So by the time you get across the hall, you've x-rayed the specimen, and you say, oh, we have everything we'd like. You know, we have enough tissue here. We feel comfortable with this. If we don't, we might have to go back in and take a few more samples, all the while, you know, the patient's laying on the table, and it takes some time to do that. Our new system, the Brevera system here, is a more advanced system where it's still a stereotactic breast biopsy, but in the past we used to only be able to do that on a 2D image, but now we can actually do it on a 3D image. So if we see something only in 3D, we can set up the machine to look at it in 3D. And while we're taking the sample, instead of leaving the room, this time I can take 2 or 3 or 4 samples, and the machine will x-ray right in front of me. So I can see, yeah, we're getting the spot we like, and we can be done. So it probably cuts our procedure time in half. The amount of time the women have to lay on the table is much shorter. Right. I think it's more precise. The fact that we can see things on 2D and 3D is really helpful. So we've had that for a couple months now.
Yeah, when did you?
Been going great.
Did we do it in May? I mean,
so we started in May and June. Kind of June is when we fully kicked off with everything being backed up, supply chain issues and everything under the sun. It took a little longer than we had hoped to get it in. We initially got the beginning parts of the machine in March, and we've really started to use it in this summer, really.
So if you're watching, we're at the beginning of August right now, but it's been in place for a couple months
now. Yeah.
I mean, do you like the technology?
It's great.
Is it
so
easy
great. Yeah, so great. And if you remember, you wouldn't remember, but after we take a biopsy, we'll typically put a marker in place where we've done a biopsy afterwards to see, yes, did we get the site that we're concerned about? We put a marker there. Let's say most of the time biopsies will be benign, but sometimes they won't. And let's say it is a breast cancer. That marker helps us target further imaging down the road. So maybe we need to take maybe this time Dr. Ed or Dr. Welch or somebody needs to maybe take a larger sample to sample the whole area, or to take the breast cancer out, or for treatment. They know where to go. So after we do the biopsy, put a little marker in place, little tiny thing. We'll take a mammogram just to see that we've addressed the site of concern, and go from there.
And am I correct? I was doing a little bit of research before this interview. It's the first in the world to be the first biopsy system to unite tissue acquisition. So you're grabbing that tissue in real-time imaging. He's looking at it. And then post-biopsy handling in the system. So right there, you're doing every three.
It's all sealed in one. Actually, really small machine. I mean, it's amazing. And as I'm taking a sample, you know, the breast, the little biopsy needle is in the breast, and there's a vacuum-assisted device. So as soon as we take the sample, it takes the little piece of tissue, it goes down the tubing right into the machine, and the machine x-rays it. And I can see it on the screen right as I'm doing it, like within seconds. So it's great.
If I have to get a biopsy done, will I know if I have a cancerous material in my breast at that time?
So we know that we have the site of concern, but we don't always know if it's malignant or benign.
Okay,
so that goes off to the pathologist. Yeah.
Got it. Okay.
So and that's usually a day or two. So we're always watching for those results, and some conditions
a day or two isn't long.
Yeah, it feels long though when you're waiting.
Yeah, I bet.
But it's much it's much quicker than it used to be.
Yeah.
And some conditions will be maybe a precancerous condition, and they might say, well, we need a little bigger sample, or some will maybe just totally benign and we're done.
Yep.
So it's a really slick and fast, and we're so thankful that we
Does it hurt to get a biopsy done?
So when we first numb up your skin, it's annoying like anything.
Like a
we
needle?
numb up the skin, yeah.
Okay.
There's a small incisions about that big, maybe less than a centimeter. And as we're doing the biopsy, there's a second set of tubing that goes in there, and it actually flushes out the whole air with like lidocaine and saline. So you're getting numbing the whole time while we're doing it.
Oh.
So we try to make it, I don't want to say it's non-painful all the time, but most of the time people were like, oh my gosh, that's it? That was great. You know, they're
Good.
expecting it to be really painful. And the majority of the time it's great.
Yeah.
So.
And just in lieu of breast cancer coming up in October, you know, always be doing your breast examinations. And if you feel something, go to your primary care doctor first.
True.
Or your OBGYN, and just make sure that you're getting in sooner the better.
Yeah, and that's really important, especially people think, I mean, mammograms are not perfect. They're good, and tomosynthesis, the 3D mammograms are good too, but they don't always pick up everything. So we get the majority of things, but some things we find only by maybe a woman notices a difference in her, you know, in the texture of her breast, or maybe feels a lump, or her physician does. So those are really important to follow up on, I think.
Yeah,
So.
yeah. Well, I can't thank you enough, Dr. Graham, for coming in here. I've been pestering them for a little while because I was told we had this new technology, our new table. It's a new table as well.
Brand new, the whole,
Right.
So our last machine was end of life. We had it here for 9 years, and most radiology equipment lasts 5 to 10 years or so. So it was end of life, and it was just a good time to do the table. We actually did some site visits, and they came here and showed us, and we found the system that does it all in one. We were like,
Let's do it.
we got to have that one. So
That's great.
so we're really happy to have it.
Perfect. Yeah, but if you have any questions, of course, we always put our information down below. But please just let us know what we can do for you. If you know of other things that are out there, other healthcare systems, we like to know. And so, but right now, we think we've got, I think, the best system in place.
Yeah, it's really good.
To help our women. So thank you again, Dr. Graham, for being here. And please, again, subscribe, like, or share this podcast with others. And have a great day.
Thank you for listening to CRH Talk. Please subscribe, rate, or share this podcast. Check us out at codyregionalhealth.org and see what services we offer locally in Northwest Wyoming.